right, we are back. So if you are joining us, David is here with us. If you are joining us post live class, we are starting at the video about 20 minutes in, and we may fast forward through it if Terry says there's something that's really not conclusive to our needs. We may fast forward through that. So if at some point in time, David, if you don't have sound, David said the last video was just getting interesting. Please tell me, how does it end? And I thought it ended.
It did. We stopped on the cyanide. We were only going for the cyanide.
We only went for the cyanide, but we can give you the link to the video if you would like to watch it. Oh, sarcasm, he said. Okay.
Oh.
I'm not good at sarcasm, especially when it's coming through text. So, haha. Social cues. Okay. All right. So this is on strangulation. I'm gonna turn my camera off. We're not staring at a wall. Don't need that.
Someone's choking you?
No, it's saying we're having a DV, but she's having an asthma attack talking to us.
What's a DV?
It's domestic violence. He pushed her.
Ma'am?
Yeah.
Okay, where is the person that pushed you?
So I've done this presentation, I don't even know how many times, probably hundreds at this point. Every time I listen to that recording, it just pisses me off, and I want to reach through the telephone and punch that dispatcher. But what this boils down to is lack of training. They don't understand the severity of this, so both dispatchers minimized this recording here, both in this one and in the one that Gail played earlier. You heard them ask, do you need an ambulance? Do you need a paramedic? Don't even ask the question. If this is near fatal strangulation, if this is domestic assault battery, send the ambulance. We'll expend the diesel and we'll go back home if we're not needed, but we need the ambulance on scene initially to help get these people to the hospital. So again, one sees what one knows. Not only do we need to train our pre-hospital care providers, our EMTs and paramedics, we've got to train our dispatchers as well. So when we look at some signs and symptoms from some San Diego police reports years ago, it's all over the board as far as what things these victims can report. You heard in both these recordings, he tried to break my neck. Why can't I breathe? My voice sounds different, all of those things. One key thing here that I want you to remember, because I'm going to hit on this several times, is urination and defecation. When it gets to that point, that's bad. I use the term attempted murder, and that is very true when we get to that point. So we're going to go through all of these signs and symptoms in a little more detail here in a little bit, but first, let's look at some statistics. Excuse me. 1 in 4 women will experience intimate partner violence at some point. 10% of those will be a strangulation assault. This is predominantly a male dominated crime. 99% of the suspects were male, and 50% of those had a previous history of some type of domestic violence in their past. Some of the problems with prosecuting strangulation is that a lot of times it's a crime where there's no visible injuries. And so 50% of these victims have no visible injuries. So again, it is incumbent upon us in both law enforcement and EMS to document what they tell us, to document what we see on scene, etc. 35% of the victims have injuries. However, they're very minor and they can't be photographed very well. So we need to be taking pictures, not only today, but we need to take sequential pictures through our forensic photographers. Only about 15% of the victims do have injuries that are sufficient to photograph. And certainly when we see those, we need to record and document those with photographs today, tomorrow, a week, a month later, so that we can track that. The problem with all these injuries is that only about 3% of victims actually seek medical attention. And that's where EMS can help us change that, because for those of you that are listening today that are in pre-hospital medicine and do EMS, you know that we can sway someone's decision to go to the hospital simply by saying, oh, you don't want to go to the hospital, do you? Or I really need you to come to the hospital with me. This is important. And as we progress through this today, I think you'll learn some things that you can stress to the victims as to why this is important and we need to get them to the hospital. Women victims are 8 times more likely to be killed by their partner. About half of women murdered in domestic assaults are victims of previous attempted strangulations, and about half, 45% of women who are victims of attempted murder in the past were strangled. So this is a bad crime. This is something that we need to work on, both with law enforcement, with EMS, with the judicial system, with prosecutors, with probation officers. Everyone involved needs to learn more about this so we can keep these guys behind bars. One thing that we all know in, working in the hospital, working in the ambulance, et cetera, is patients don't often volunteer information. Some do, but most of the time we have to pry that information out of them. So if you don't ask the questions, they're not going to tell you. But first, we have to know what questions we're going to ask to be able to get the appropriate information. So as we move through this, take some notes. Hopefully you'll learn a few things that you can ask the victims. Did this happen? Do you feel this, etc. Gail kind of alluded to the fact about minimization, and you heard both the dispatchers say, oh, it's just a DV. She's just suffering a DV. Well, it's minimized all through the system. The defendants say, why are you arresting me? All I did was choke her. The victims, he didn't really choke me. He just had me in a headlock and I couldn't breathe. Well, I don't know what your definition of attempted murder is, but if you can't breathe, the next step is death. Dispatchers, they often don't recognize this and they trivialize it. I did this presentation for Maine EMS several weeks ago, and one thing I found out there is that all their dispatchers are required to be trained through the state. It's not the case in Oklahoma, and that's not the case in many states. And so we need to help train our dispatchers to recognize this so they can send the appropriate response. Law enforcement and EMS, they're inadequately trained, I can tell you that. I am a commissioned deputy sheriff and went through the Law Enforcement Academy, and the amount of domestic violence training we received, you could put in a thimble. However, the amount of domestic violence calls that the law enforcement goes on a typical day would fill a dump truck. So there's a disconnect between the amount of training received and what actually happens in the field. Courts need expert witnesses. It's hard for a prosecuting attorney to explain to a jury why this is attempted murder without an expert witness. So jurors have to understand the severity of this. So you need expert witnesses. There's also typically lack of findings. Where are our significant findings? So if there's lack of injuries, then the judicial system typically minimizes the seriousness of this strangulation. Victims don't understand the consequences, and that's where, again, as we go through today, you can write some of these things down to tell them it's not just today. You can have problems down the road after this near fatal strangulation. Lack of laws and protocols. Agencies or jurisdictions that do this best have a system-wide approach, which is the next one. So if we have a multi-jurisdictional or multidisciplinary team, then we're able to help put these guys behind bars a lot faster, a lot better, and a lot easier. So there was a recent study from victims that were seeking protective orders, and it asked them, how were they potentially strangled? Where did it happen? How long did it last? And so that how long did it last is important. 39% said less than 30 seconds. Keep that number in mind as we kind of move through this, because we're going to talk about that. 15 seconds and 30 seconds. Was suffocation involved? Remember the arrest affidavit I read you earlier? He went to look for duct tape to cover her mouth. Okay. How much pressure was applied? A severe amount of pressure. Who knows what that really means, but we're going to actually talk about that. What did you think was going to happen? I thought I was going to die. So when you can't breathe, what do you think? You think you're going to die. So again, attempted murder. Why did it stop? Because he calmed down. It didn't stop because she wanted it to. It stopped when he wanted it to. Did you call the police? Yes. Did you seek medical attention? We want that did you seek medical attention to be 100%. And as we go through this, again, you'll learn why that's important. So is your breathing different now? 37% said they had difficulty breathing. Okay, so that's important. You heard both of these audio recordings from dispatchers that they were having trouble breathing. I was suffocated, I can't breathe. Some additional questions here that were from these victims of protective orders. Does your voice sound different? Yes. Do needs water to eat because food's not going down appropriately, and we'll learn why. Do you have trouble swallowing? Did you lose consciousness? Here's that urination and defecation again. Did you have a loss of bodily function? 42% said that yes, they urinated on themselves, and 17% said they defecated. Again, keep those two things in mind because we're going to hit on that in a lot more detail in a minute. Do you experience headaches, dizziness, seizures? So this is long-term consequences, both of these here. Have you experienced since the event restlessness, agitation, amnesia, PTSD, hallucinations, etc.? So these are all things that we're going to kind of touch on briefly that can happen after this initial strangulation event. So we throw out a lot of terms. What do they all mean? You know, choking, strangulation, asphyxia, hypoxia. What do all these terms mean? Are they the same? Are they different? Well, so we do need to know the differences in some of these terms. So when we're talking to the victim, when we're writing our report, et cetera, we use the appropriate terms. So anoxia, an means without or the absence of. So anoxia is simply the absence of oxygen supply. So if we think about the brain and we compress the carotid arteries in the neck, that instantly shuts off the oxygen to the brain, and so the brain becomes anoxic. Hypoxia means that oxygen level slowly decreases over time. So the deficiency in the amount of oxygen reaching the tissues, which can happen with decreased or slow blood flow. So here's a graphical way to represent that. Anoxia is just boom, it happens. Hypoxia occurs over time. So what happens in the body with hypoxia? Well, in the neck, again, in the area of the carotid arteries, there are specialized cells called the carotid bodies that detect oxygen levels, they detect our heart rate, things like that, our blood pressure. And so in response to this decreased oxygen level or this hypoxia, the carotid bodies send a signal to the brain that says, hey, something's not right, you better fix this or bad things are going to happen. So it increases our breathing rate, it increases our heart rate, it triggers that fight or flight mechanism because the carotid bodies in the brain have now recognized that there's decreased oxygen and we can't survive that. So that's just the body's protective mechanism to get around that. Those of us in the medical field, we all hear time is muscle, time is whatever. Well, time is also brain. And so with anoxic insults, you can lose upwards of 32,000 neurons per second when the brain is anoxic, and you can lose upwards of 230 million synapses per second. I know there's people on this from all over the country, and I assume you have the same as in your areas that we do here. We have people that can't afford to lose a single neuron just because of the way they are. So we need to prevent that from happening. So let's talk about some more definitions. What is suffocation? Well, suffocation is simply obstructing oxygen from getting into the lungs, okay? So sealing the mouth and nose, okay? A pillow over the mouth and nose. Duct tape, you heard that mentioned earlier, okay? Head inside a plastic bag. Sitting on the chest. Whatever the case may be, it's not getting oxygen in and out of the lungs, because the main two main things that keep us alive are blood goes round and round and air goes in and out. If those don't happen, then we die from that. So that's what suffocation is. So suffocation can either be smothering, choking, confined spaces, etc. There's various ways of suffocation. Now, what it is not is it's not choking, okay? We use that term interchangeably sometimes, but strangulation is absolutely not choking. Choking occurs when a foreign body lodges in the throat and gets stuck. So your mom told you to chew your food so you don't choke on it, and that's true. This is if we don't chew our food and something gets stuck from, instead of going down the food pipe, it goes down the windpipe and blocks oxygen from getting into our lungs. That's what choking is. Then there's also a term called asphyxia. So asphyxia is a condition that arises when the body is deprived of oxygen, ultimately can cause unconsciousness, death, or suffocation, okay? So just like there's various types of strangulation, or suffocation, I'm sorry, there's various types of asphyxia. So there's positional asphyxia. As an example, maybe falling in a weird position, the neck is turned and you can't get air in or out, okay? There's traumatic asphyxia. So an example I use there is the farmer who's working on his truck, underneath it with a jack. The jack falls, the truck falls on the chest. If I can't expand my chest to breathe, that's traumatic asphyxia. And then there's drowning, which is a type of asphyxia that occurs by immersion in a liquid. Strangulation, which is kind of what we're here to talk about, is a form of asphyxia characterized by closures of either the blood vessels or air passages as a result of external pressure to the neck. Okay, so some form of external pressure was applied, whether directly, whether from behind, whether from the front, and it either shut off the blood vessels or it shut off the air, the windpipe, the trachea, and we're going to look at that. So ligature strangulation, that's one form, and we see that a lot of times in attempted suicides or suicides. If you look at this picture, you can see it looks like this is an extension cord. There's two very distinct lines there as a result of the ligature, versus manual strangulation, where there is a much broader line. And so this could be hands from the front leaving all these marks. It could be hands from the back. It's hard to say, but manual strangulation typically leaves a much broader bruise area or a much broader finding than ligature. To truly understand what's happening, we got to do just a little bit of anatomy. We need to talk about some muscles, bones, blood vessels, etc. So in the neck are several several muscles. These muscles cover the major blood vessels. Okay, and so one of the important muscles is what's called the sternocleidomastoid muscle. So this hooks into the mastoid process, which is the bump behind the ear, and then goes to the sternum, and then goes back to the clavicular head, or the back part. This covers both the carotid artery and the jugular veins that we'll look at in a minute. But first, I want to show you another picture that has a structure that's very important, and this is the hyoid bone. So the hyoid bone is important for us when we phonate or when we talk. It's what raises our tongue up and down, helps us to make different sounds. It's also what helps us swallow and form that food bolus so that food goes down. It's a unique bone in that it is the only bone in the body that does not articulate with another bone, okay? This bone is also unique in that it is easily broken in either strangulation, whether from ligature or from manual. We see this bone frequently broken in hangings. The other things that are important on this particular picture, of course, the thyroid and cricoid cartilages that form kind of the upper airway and larynx, and then of course is our trachea or our windpipe is below that. Next, remember I said that air goes in and out and blood goes round and round. Well, here is the blood into the head. So coming from the heart through the common carotid artery, which then splits into both an external and an internal carotid artery. The external supplies the structures of the face, so my forehead, my cheek, my mouth, etc. And then the internal carotid artery, dives inside the head, and that's what supplies the structures inside the brain. You know, the frontal lobe, the parietal lobe, all the parts of the brain, that's what the internal carotid artery supplies. Well, if we have blood that goes in, then we have to have blood that comes out. And so the blood that comes out through both the internal and external jugulars, just like the internal and external carotid arteries. So again, blood goes round and round. We've got to get blood into the head, circulates around inside the brain, and then the blood comes out, okay? If we stop that, bad things can happen. And we're gonna talk about that in just a second. Here's just another kind of picture that shows all of that put together, the carotid artery, the internal and external, the internal jugular, the external jugular, the thyroid cartilage, cricoid cartilage, hyoid bone, all of that stuff put together. Another picture of the hyoid, and again, the only bone that doesn't articulate with another bone. We also need to know a little bit about neuroanatomy to understand why perhaps sometimes the victims don't remember what happened, okay? And so in the brain, in kind of the lateral side or the side of the brain deep inside of there is a part called the hypothalamus, the amygdala, the limbic system, so to speak. And that's what helps us form memories. Okay, this limbic system is composed of an important part called the hippocampus. It's located in the medial temporal lobe, so over here on the side, Latin for seahorse. Part of the limbic system. It helps us deal with emotions, but why it's important for us is that it takes short-term memories and helps us form long-term memories. So the stuff that you're remembering right now, your limbic system and your hippocampus are spinning around in there and forming long-term memories, so that a month, 6 months, 3 years from now, and something triggers you, you're going to remember, oh, I remember that presentation where we talked about forming long-term memories. One of the things that we found, and I'm going to go over how we found that, was that the limbic system, or the hippocampus, is one of the areas of the brain that is most sensitive to hypoxia. So let's think about that for just a second. If it's the most sensitive area to hypoxia, and I get strangled and there's no oxygen to my brain, so I've had a memory or something that happened, now I have no oxygen, did I form that long-term memory? So keep that, excuse me, keep that in mind, because that is why sometimes victims don't remember what happened. Various things can happen in the brain. The amygdala is our emotion or alarm center, so that fight or flight. The hippocampus helps us store memories. The thalamus translates sight, sounds, and smells into the language of the brain. So sometimes victims may remember a specific smell. It smelled like smoke. I heard a train. Things that may not mean anything to us, but their memories are jumbled up because they didn't form those long-term memories. And so other parts of their brain are using all the senses they have to help us remember this stuff. So what is it that we can do to help in EMS? Why is it that it's important for us? Well, one is we have to be able to recognize the signs and symptoms of strangulation, okay? And so we're going to go through those. But first, we kind of need to understand the difference between a sign and symptom. So a sign is the body's response to something. So vital signs, heart rate, blood pressure, respiratory rate, etc. Those are vital signs. So a sign is something that I can see. It's an objective finding versus a symptom, which is something the patient tells you. Sometimes these are vague. They're very subjective. My throat hurts. That's a symptom. My voice sounds different. That's a symptom. Versus I can see a bruise. That's a sign. Regardless of whether this is a sign or a symptom, this is the body telling us something's not right. This is the body's way of letting us know that homeostasis, the normal way of everything happening, is not happening smoothly now. So let's look at some various signs of strangulation, things we can see. Scratch marks, bruising, fingernail impressions, petechiae, and we're going to go through petechiae in a little bit more detail. Swollen tongue, swollen lips, bite marks, bruising under the chin, any number of things can be seen. Red face or neck. These are all signs or stuff that I, as the evaluator, the pre-hospital worker, the physician, whatever, these are all things that I can see and document. I need to put on my report that I saw these things. Versus some symptoms. Ma'am, are you having any difficulty breathing? We heard that on both dispatch tapes. Is it tender at all under your chin? Does your voice sound like it always did? Have you vomited? Are you coughing? Does it hurt to swallow? Do you have any neck pain? Urination and defecation. There we are again. Ma'am, are these the same clothes you were wearing when this happened? No, I changed clothes. Why'd you change clothes? Well, they got dirty. Well, how did your clothes get dirty? So again, if we don't know what questions to ask and why we're asking them, they may not volunteer that information. She doesn't know why she woke up and her pants were wet or she soiled her pants. So we may need to ask those questions, because that is a huge sign that tells us this event occurred for at least 30 seconds, and we're going to see that. One of the things on the Dropbox and the Strangulation Institute's website are these cards that can be used that show various signs and symptoms. There's an adult card, there's a pediatric card, they're in a couple of languages. So these are cards that you can download and print and throw in the back of the ambulance with you. So you've got these if you forget. They're cards that you could show the victim and say, hey, look, these are things that can happen, etc. So download those from the website. So what are petechiae? So petechiae occur when capillaries break open. Very small, 1 to 2 millimeter in size, and you can't feel them. They're smooth. And so remember I said blood goes round and round. Well, if I've got blood that goes into my head through the carotid artery, but I somehow occlude the jugular vein, so blood's going in, blood's going in, blood's going in, pressure's building, pressure's building, pressure's building. Somewhere that pressure burst, and the place that it can potentially burst is in these capillaries. These capillaries are very small. They're the thinnest blood vessels, the smallest blood vessels, so we see these little tiny petechiae. You can get these from coughing, vomiting, breath holding, asphyxia, any kind of constriction. We can see them on the face. We can see them inside the mouth, on the gum line. We can see them on the hangy thingy in the back or the uvula. We can see them on the victims, and so there's a well demarcated line. So where this pressure to the neck was applied and those blood vessels were occluded, pressure built up above that and those blood vessels burst. Okay, so again, we need to ask those things. So now let me ask a question. If the external carotid artery and the external jugular vein supply the face, and I've created this, created this petechiae, the internal carotid goes into the brain and the internal jugular drains the vein or drains the brain. So if I create petechiae on the skin, can I also create petechiae inside the brain? Well, the answer to that is yes. Well, what by definition is a ruptured blood vessel in the brain? A stroke. So ruptured blood vessels inside the brain or petechiae in the brain can be a stroke. Can you see that? No. Can I see that? No. Can we see that with a CAT scan or an MRI? Yes. So do we need to get these victims to the hospital to have potentially additional testing? The answer is yes. Another thing that can happen is what's called a subconjunctival hemorrhage. We see these in the emergency room all the time. People come in freaking out because there's blood in the whites of their eye. This is just simply another busted blood vessel. Similar to petechiae, it's from a busted, very small blood vessel in the eye. We can see this from a coarse strangulation. We can also see it from vigorous coughing, vigorous vomiting, things like that. It looks terrible, but it goes away. But for us, it is a telltale sign that there was increased pressure from whatever reason. So we need to document that. We need to document where we saw that, the extent of that. We need to take a picture of that because this is going to ultimately go away. And we need to be able to show the jury, here is a subconjunctival hemorrhage. This can occur from strangulation or pressure applied to the neck. Scratch marks or claw marks. Why do we think we saw this? Well, we see this because she's trying to pry his hands off of her neck to save her life because she can't breathe. She can't get air in. She's doing everything she can to save her life because remember the quote, I felt like I was going to die. Another thing we might see are battle signs. Now what a battle sign is bruising behind the ear or can be a sign of a basilar skull fracture. And you might be thinking, how can strangulation cause a basilar skull fracture? Well, just picture with me, if you will, a 5'4" victim and a 6'6" perpetrator who is strangling this person from the front, strangling, 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 strangling. She becomes unconscious, strangling, and all of a sudden he finally decides he's done and lets go. Where does she go? Right down to the floor, hits her head, and could potentially suffer a basilar skull fracture and end up with that battle sign. Now again, in this first picture, kind of easy to see with short hair, but you got to look. You got to know to look. Now this victim who has longer hair, if we don't look, we may not see that. The other thing is, do you think she sees this? Probably not. So again, we got to know what to look for. Here's an example of ligature strangulation. So when we see that, and I think if you look closely, you can also see some petechiae above that. What about some symptoms? What are some symptoms of strangulation? Just like the other stuff, you got to ask the questions because they may not know that these symptoms they're experiencing are as a result of this strangulation. Ma'am, does your voice sound the same? Maybe ask her friends who are there or children. Does mommy's voice sound the same now as it did yesterday? No, it sounds raspy. It sounds scratchy. That can be a sign of strangulation. Does it hurt when you swallow? Do you feel like your breathing is any different? Have there been any behavioral changes? So over the last week, if this is, several days after the event, have you felt anxious? Have you had anything that's different today than before? So why could the voice be different and why could swallowing be different? Well, what's called the recurrent laryngeal nerve, which is a nerve that comes off the vagus nerve, goes way down into the chest, circles back up, and ultimately supplies my voice box, is what helps me swallow and helps me speak. Just like when you bang your elbow and you get that funny bone sensation, that's actually what's called a neuropraxia, or a bruised nerve sensation. Excuse me. Well, if I can bruise that nerve from banging my funny bone into a door, into a wall, or whatever, can I not bruise that nerve in the neck? And the answer is absolutely yes. Well, if I bruise that nerve in the neck, and that's what supplies the vocal cords and the voice box and the muscles in the neck and helps me swallow, so that electricity is not getting through there like it should, I may not sound the same, I may not be able to swallow the same, I may not be able to talk the same, all of that because that nerve is bruised. So some changes that can occur are what's called dysphagia or odonophagia, either difficulty in swallowing or painful swallowing. Some things that can happen both initially and then more long-term are behavioral changes. Perhaps she woke up fighting. Remember, our limbic system helps us form those long-term memories. So if she all of a sudden wakes up on the floor and has no idea what had happened, she could potentially be hostile on scene and wake up fighting because she doesn't know what just happened because those memories aren't there. All she knows is I woke up on the floor and I have no idea why. So keep that in mind. Long-term things that can happen: psychosis, amnesia, personality changes, progressive dementia. So these little tiny strokes in the brain, you could equate that to chronic traumatic encephalopathy that football players experience from repeated blows to the brain, okay? We're still learning more and more and more about that every day, but we do know with these repeated insults, that can result in dementia. Problems with memory, concentration, sleep, headache, depression. So if this strangulation event just occurred 10 or 15 minutes ago, and we're the first responders on scene, these may not be things that have happened. But if I'm evaluating this person a week from the event in the hospital, in the doctor's office, or they finally decided to call the ambulance, maybe these are things I need to ask the victim. Have you had trouble sleeping? Have you had trouble with your memory? Any of those types of things. Let's shift gears a little bit and look at a study from 14 filmed hangings and see what we learned from that. So they filmed 14 hangings and looked at what happened and timed it. So there's some things that we can gather from this. The victims became unconscious within about 10 seconds. They had what's called an anoxic convulsion within about 14 seconds. Now, those of you in the medical field, you probably all heard this, in that a patient was brought in and family members said they had a seizure. Well, seizures to the lay public and to us are two different things. You know, an anoxic convulsion can look like a seizure to the general public, but it's really more of just that quick jerking when they pass out, okay? It can occur for a few seconds, but certainly not minutes like seizures can. So it's an anoxic convulsion from the brain trying to basically hit the Control-Alt-Delete and reset so it can start breathing. We also found from this hanging study that within about 77 seconds or a little over a minute, we lose muscle tone, and anywhere from a minute to 3 minutes, our last respiration occurs. So what does it take to occlude these structures in the neck? Okay, we've talked about, you know, carotid artery, jugular vein, etc. Well, to occlude the jugular vein, and everybody should know, I mean, everybody in the medical field should know, veins are much weaker than the arteries. So it takes much less pressure to occlude the jugular vein, only about 4.4 pounds. It takes about 11 pounds per square inch to occlude the carotid artery and about 34 pounds to occlude the trachea. So let me ask real quick, and somebody just type it in the chat box there if you would. How many of you that own a gun know what the trigger pull is on your gun in pounds per square inch? So I'll try to put this into perspective, because when you pull that trigger, it requires a certain amount of pressure to pull that trigger. And you'll see if anybody answers here. Yep, somebody says about 6 pounds. That is about right. It takes between 5 and 6 pounds of pressure to pull the trigger on a gun. So anybody that's ever fired a gun can easily occlude the jugular veins, okay? When you open a soda can, that takes about 20 PSI to open a soda can. So anybody that can open a soda can occlude the carotid artery. A normal adult male handshake is about 80 psi. Well, it only took 34 to occlude the trachea. So anyone on this chat or on this video presentation can occlude the jugular vein, occlude the carotid artery, and occlude the trachea, just because we know you can do those normal things. So it does not take much pressure to do that. This is, as they say, an oldie but a goodie. This is a very old study, but at the time, it was fairly earth-shattering, so to speak. So in 1944, they looked at neurological insults to the brain. This was a study conducted by some naval officers. What they developed, or what they did, was they developed this device that essentially occluded the carotid artery and the jugular vein in test subjects. So they used 11 schizophrenic patients and 126 inmates, and they performed well over 500 controlled strangulations. What they found, which seems kind of obvious to us today, but what they found was that the neurons in the brain are the cells of the body that are most sensitive to anoxia. In 1944, this was fairly earth-shattering. Today, just seems normal to us, but we know because of this study that the limbic system, the hippocampus, those are the areas of the brain that are most sensitive to oxygen deprivation, and therefore the areas that why we can't form these memories. Some other things that they found was within about 5 to 10 seconds, the victims fixated their eyeballs, they had blurry vision, they had constriction of their visual fields, ultimately lost consciousness within a few seconds, then had that anoxic convulsion, okay? These convulsions were preceded by a loss of consciousness, and interestingly enough, the victims really had no memory of that seizure or that anoxic convulsion. So I want to kind of put this all together with a video here. If it plays, we're going to cross our fingers.
BJ Penn is one of the best submission artists in the UFC. It only
Where would he go?
Keep going. Well, I don't know, it's on the brain study now. Seemed like it was really, really long, but.
So you want to watch this?
Okay, yeah.
takes 5 pounds of force to choke someone out. That's less force than it takes to break an egg. But our data shows that BJ can deliver 34 times more force than necessary. To find out exactly what happens during this submission, we're going to wire me up with the most technology ever used to study the rear naked choke. Time to sacrifice my body for science.
So we put 3 different types of equipment on John. We put an apnea sensor, which will tell us blood flow in his frontal cortex. We put an EEG, which will tell us the electrical activity in his brain. And then we put a heart rate monitor that will also give us a respiratory rate.
You definitely don't wake up and say, I can't wait to get choked at work today. Do not try this at home. I'm only doing it because I'm going to be in the hands of a pro. Come on. Wait, no. No, don't press my leg tight.
3, 2, 1, choke.
Did I get choked out? Do we get him?
Yeah.
Our unprecedented data reveals exactly what happened moment by moment. Although the brain is only 2% of the body's weight, it utilizes 20% of the body's oxygen. And when BJ's forearms compress my carotid arteries, the blood flow, therefore oxygen supply, is reduced by 13% to my brain. 3 seconds in, muscle activity more than doubles. At 6 seconds, my vision starts to go. First, color fades. Then, a black curtain closes in for my peripheral vision. This curtain is the last thing I remember. At 8 seconds, interaction between the 8.2 billion neurons in my frontal cortex has stopped, halting my short-term memory. And at 9 seconds, I'm out cold. My brain is in survival mode and powers down my entire body. My heart rate drops from 124 to 80. Respiratory rate drops by 55%. At this point, electrical activity in my brain has been reduced by 65%. After BJ releases the choke, my heart aggressively pumps to push oxygen-rich blood back to my brain at 12 milliliters per second. And amazingly, the world's most sophisticated computer, the human brain, reboots in only 3 seconds. And the only residual effect is a 5-second gap in my memory.
Did I get choked out? I thought we had not done it. I felt pressure and then I was talking again. I did not feel passing out at all.
In the UFC, 95% of fighters tap out before losing consciousness. And because of the rules in the octagon, no one has ever been seriously injured because of a chokeout.
I way rather get choked out than knocked out. No cuts, all your teeth are still in your mouth. Right. Got nothing to worry about.
We discovered some incredible data, but make no mistake about it, choking is dangerous business, and it's best left to the pros. For Sports Science on ESPN, I'm BJ Penn.
Sorry, got to figure out how to get this back now. Okay, so one of the things I want to point out there that is, of course, different than what we're dealing with. One, you notice that the second that he was unconscious, he let go. So the second that he went limp and lifeless and had that little anoxic convulsion, he let go. When does our strangler let go? Whenever the hell he wants to, okay? When he's done is when he finally lets go. Is that 5 seconds? Is that 10 seconds? Is that 3 minutes? Is that 10 minutes? Who knows? But the longer that the brain is without oxygen, the worse the outcomes can be. And so here's kind of putting that timeline together. And this is another card that's available on the Institute's website that kind of puts all these times together for us. So at time 0, pressure is applied to the neck. And so let me stop right there and pause for a second. When we're a dispatcher and we're interviewing these people, when we're a police officer and we're interviewing these victims, when we're a fire EMS or whatever, you've heard various terms: choking, strangulation, suffocation, all of that. Perhaps we should say, did he apply pressure to your neck? Okay, that seems very, very logical to us, but to the victim, they may not know the difference between, no, I wasn't choked, he just tried to break my neck. Well, those are the same things to us. So maybe we need to ask, did he apply pressure to your neck at any time in any fashion? Okay, so if pressure was applied to the neck at time 0, within about 7 seconds, the victim can become unconscious. Within about 14 seconds, they can have that anoxic convulsion or that anoxic seizure. Within about 15 seconds, they can lose control of their bladder or they can urinate on themselves. So again, like I alluded to earlier, ma'am, are these the clothes you were wearing earlier when this happened? No, I changed my clothes because they got dirty. Well, why'd you change your clothes? How did they get dirty? We have to investigate that and figure out, why did they change clothes? Why did they need to do that? Well, perhaps it's because they either urinated or defecated on themselves, okay? And then the timeline goes again all the way up to 152 seconds. Between a minute and almost 3 minutes, the last respiration can occur. So we kind of hit on a few things about what can go wrong, but what could possibly go wrong? And so these are all from various journals, various studies. Obviously, we can die either within hours to days to months after a strangulation. Death can occur. We can get a delayed stroke. Months to years later, there can be a stroke that can occur from this anoxic damage. We can get what's called, excuse me, anoxic encephalopathy. Encephalopathy basically just means that, of course, things aren't normal in the brain, okay? So you can get brain damage from blockage of blood flow, okay? The thing that's interesting here is this is in the Journal of Forensic Science. You don't want to end up in the Journal of Forensic Science. That's a bad day. Okay. Acute anoxic encephalopathy, again, so damage to various areas of the brain because these are the most sensitive to the lack of oxygen. You can also get delayed encephalopathy. So days to weeks after this strangulation, we can also get brain damage. What about tears to the spinal cord? Remember I said choking, strangling, let go, bam, falls just right, neck twist, bends, etc. So we can get damage to the spinal cord as well. Seizures, we mentioned that, those anoxic convulsions. Sphincter incontinence. This is the important part right here, in that if this occurred, then that brain was without oxygen for an extended period of time. And so then again, to use the term, this is attempted murder. What's a carotid artery dissection or carotid artery hematoma? So basically a dissection is all of our blood vessels have multiple layers of tissue. So it's not just a single tube, it's a tube within a tube. Well, if the blood supply dissects between those two tubes, and instead of going through the middle and the blood gets in between those two layers, that's what's called a dissection. Okay, so those layers separate from each other. That's bad. That can result in a blood clot. It can result in a stroke. Any number of bad things can happen from that. It can result in a carotid artery hematoma. And so if we form that dissection or that hematoma in the neck, I'm going to say not a big deal if it's in the neck, but what happens if that breaks off and goes to the brain? Then a blood clot in the brain, again, by definition, is a stroke. So it is a big deal. So can I see that? Nope. Can you see that? Nope. What sees that? CAT scan and MRI is what sees that. So we need to get these victims to the hospital to get the appropriate imaging so that we can find this, we can diagnose it, and we can treat it. Airway swelling, respiratory failure. I mean, I've seen this in person on hangings. And when we create that pressure because the blood is going in but not coming out, then we can swell. And so that's a bad day. That swelling can occur immediately, or it can occur over time because of tissue damage, bruising, and things like that. So that's a bad thing. Thyroid storm. The thyroid sits right here in the middle of the neck, and the thyroid's what releases hormones. Well, for various conditions, if there's a bunch of excess thyroid hormone and we release that because of trauma or damage, then that can result in thyroid storm, which is a fast heart rate, sweating, diarrhea. There's a bunch of things that can happen from thyroid storm. Vocal cord paralysis. Remember, again, if I bang my nerve or I bang that nerve in the neck, that can result in problems phonating, problems swallowing, elevating the hyoid bone, etc. Hyoid bone, I can break that. I can break the thyroid cartilage. Difficulty swallowing, difficulty speaking, difficulty forming food boluses, etc. Another thing that can another thing that can happen is what's called hypopharyngeal rupture, or rupture of the tissues in the back of the neck and the upper airway. And I can get what's called pneumopericardium, where I can get air that dissects into the chest that's not supposed to be there, obviously. Some long-term things, tinnitus, post-traumatic stress disorder. So as you can see, it's kind of all over the gamut, things that can occur from non-fatal strangulation or near-fatal strangulation. So what is it you can do? Well, everybody in healthcare has to write a report. Whether you use Zoll, emergency reporting, EMS charting, whatever system you use, you have to write a report when you go see these patients. So let's document that. Let's document what she said, what I saw, what questions I asked, all of those things. But more importantly, let's get them to the hospital, okay? So the victims that are fatalities, we can't do anything about, but what we can do is the ones that survive, we can get them to the hospital so that their perpetrator can be prosecuted so that they don't end up in this category. What we don't want are non-transported victims. We want every victim of near-fatal strangulation to be taken to the hospital so that they can be evaluated, okay? So we have to have proper training, we have to document it, and then they need to be treated. As I've said a bunch of times, history is super paramount here. You have to ask the questions because they probably won't volunteer it. All they know is we were fighting, he choked me, and I woke up. He tried to break my neck, I couldn't breathe, whatever, but they don't understand why. So you now do, and so you need to ask those questions. Ma'am, did you pass out? Did you fall to the floor? Did you feel like you couldn't breathe? Again, are these the same clothes you were wearing? My son told me I had a seizure. Well, can I talk to your son? What did he see? What did he witness?
We do. We have 2 more, actually. All right, so that we are right at an hour. We're going to conclude this section. Once I get this uploaded, I will put the link to the video in the description box. So if you want to go back and watch the rest of it, you're more than welcome to. We're going to take a 10-minute break, and we will be back with who's next. I think so. Am I next? Okay.
I'm done.
Do you need to go next? Okay. It don't matter to me.
Oh.
You are next for ventilation.